Right, welcome everyone to the meeting of our Health and Adult Social Services Standing Scrutiny Panel. I'd like to remind everyone that the meeting is being held in hybrid form this evening. We have some members and officers who are joining the meeting online and others that are present here in the room. The meeting is being live streamed on YouTube. Can I just remind, well, at the moment, I think it's just Anna and Louise that are logged in, but can I just remind anyone that joins online that they'll need to raise their hand if they wish to speak. So I'll move to item number 1, which is apologies for absence. I have received some apologies this evening from Connor Wood, who's one of our co-opted panel members, from David Crawley from Healthwatch Ealing, and also from Kerry Stevens, our Strategic Director for Adult Social Care. Councillor Newsturb, as the Cabinet Member, I believe is due to join us online, and I can see that Councillor Alexander is now also online as well. We are delighted to be joined by our health partners this evening. So when we come to the relevant part of the agenda, I will just ask colleagues to introduce themselves. We're also super pleased to be joined by a member of our Children's Scrutiny Panel for the Children and Young People's Healthy Weight Strategy and Paediatric Audiology items, and that is Councillor Jamu, so you're very welcome this evening. Item number 2 is urgent matters. There are no urgent matters on the agenda this evening, which brings me to the declarations of interest, item 3. So I'll start by declaring my interest as I'm employed by the Nursing and Midwifery Council. Councillor Conti?
I'm the GP in North West London.
Any other direct declarations?
Oh, I am a GP in Ealing Borough and North West London.
Any further declarations from colleagues? No. Well, we will move on. Matters to be considered in private. There are no matters to be considered in private this evening. So I move to the minutes as item 5. So this is reviewing the minutes held on the 27th of the meeting held on the 27th of November. So can I confirm that they're a true and accurate record of the meeting? Thank you very much, colleagues. We now move on to item 6. Don't worry, the rest of the meeting is not going to be this quick. Item 6, the draft work programme. So just want to stress that because we are obviously approaching the elections, there's a kind of compressed period for our scrutiny work this year. The final meeting of the panel in March is also very busy. We've got items on adult mental health services. We've got a really interesting piece on immunisations and screening, and also the role of the voluntary sector within health services as well. We're also, as a panel, hoping to have the opportunity to visit 1 or 2 of the voluntary sector organisations involved in providing some of that support to kind of bring some of our scrutiny work alive. And then I just wanted to also raise, I attended the North West London Joint Health Overview and Scrutiny Committee in Hounslow on Tuesday the 9th of December, which feels like a lifetime ago now. But we looked at urgent and emergency care, primary care access, continuing healthcare, and also special educational needs, incontinence services. And we've got a further meeting of the JOSC, which is scheduled on the 19th of March, in which we're going to be looking at cancer screening and digital health. So that's the panel work programme. Are we content with the items for the remainder of the scrutiny year? Lovely. In which case, slightly ahead of schedule, we will move to our first item on the agenda, which is the Children and Young People's Healthy Weight programme. And we've got Anna Bryden, our Director of Public Health, and Louise Taylor, who's one of our public health principals, who will provide the panel with a short presentation, and then I will open it up to questions. So Anna and Louise, you're very welcome, and over to you.
Thank you, Chair. Evening, everybody. I think I've met most people around the table, but I'm Anna, Director of Public Health. I've been here for a few years, and Louise is our super public health principal who leads on this area and has been here far longer than me. Really pleased to bring this item here. I know it's come up time and time again over the last few years as a kind of area of interest for the panel, and really getting to understand some of the data, getting to understand some of the kind of like initiatives and services around this area. I'm going to hand over to Louise to talk us through the slides in a minute, but I think one thing I just wanted to say is this is an area, so we're representing one of our partnership groups here. So under our borough-based partnership Children and Young People's Board, there's a group that Louise chairs on what we call Healthy Bodies, which covers lots and lots of different topics, but it also has a lot of our partners there. So that includes lots of our NHS partners, lots of our Children's Directorate partners, and also lots of our place partners from across the council as well. So it's really, we're here presenting on behalf of that partnership group, really. So there might be some questions we need to take away, but we'll do our best to answer this evening. This has come up as such a kind of important issue, and you'll see as Louise goes through the slides, we really see this in kind of like a whole systems approach. So this is really thinking about, yes, as services kind of at the end of the day where maybe children or families need some additional help in terms of their diet, physical activity, support around that. There might be some wider interventions to support with that kind of what we would see as a healthy lifestyle. But there's so many factors underneath this, the kind of building blocks of health that really support a kind of chance for young people to grow up healthy and for families to stay a healthy weight. So you'll see as we go through this kind of those different building blocks of health that are so important. And actually, when we talk about action plans around this area, it's covering all of those. So you can imagine this is quite broad and long term. It also means, and we've talked before here, just one last point, Chair, if that's okay, about the data. It's one of those indicators that we have in a national framework in terms of the overweight and obese data, usually at the school ages where they're measured on an annual basis. It changes slowly. The biggest change we saw was during COVID, went up really quickly 1 year and is stabilised slightly. It's one of those factors that has so many things that influence it that you will never be able to say we did that and we've magically reduced or increased obesity by X%. But what we do know is really, really good, strong evidence based around lots and lots of these building blocks that go around a healthy weight environment. And so we have confidence that we can follow that logically through to say, we know this works, we know this will help, but lots and lots of different things need to add together to give it a good environment. So if that's all right, Chair, I'll hand over to Louise and then we can come back with questions. There we go.
Okay, can you hear me okay? Okay, thank you. So this is a sort of snapshot of the more comprehensive document that is attached. So just to whip through that, really, we know that obesity is a major public health issue and it does have an impact, and I'm sure many of you are probably very familiar from lots of different backgrounds with the short-term and long-term impact on physical health, educational attainment as well, economic productivity. And we know that when children are overweight as children, there is a higher potential for them to become overweight adults as well. So it's very crucial for us to try and sort of get things into place and try and sort of get the infrastructure in place to tackle it whilst children are younger. You can see by some of the data here on the screen that in Ealing, we obviously collect the National Child Measurement Programme data. That's children at reception year, that's when they're 4 to 5 years of age, and also when they're in year 6, so that's by the time they're 10 to 11 years of age. So essentially, amongst the 4 to 5 year olds, you'll find that 1 in 5 children are above a healthy weight. And then by the time they've reached 10 to 11 years of age, it's actually 1 in 3 children. So it kind of almost doubles essentially in that short window of time. This gives a breakdown in the table of the different categories. As you can see, we're able to see it by underweight, healthy weight, overweight, very overweight. And so this strategy is essentially around the importance of early intervention and the need to address health inequalities. There's not one single silver bullet, unfortunately, to tackle this. So this strategy is designed to be a sort of comprehensive capturing of the strategies, the work, the evidence, and the work that partners are all doing collectively to try and address this. So just to set the scene a little bit, there are a range of strategies out there and work plans. Just want to emphasize, obviously, that there are different strategies which you may not typically connect as being related to a healthy weight and obesity. They may not include the words obesity or weight. We know that healthy lifestyles can give climate benefits through locally sourced and sustainable diets. So it's important to think about sort of wider perspective and things that really do make a huge impact. The economic growth strategies as well can reduce excess weight by providing more meaningful jobs, higher incomes for households as well. It's less likely to result in stress and pressure and impact purchasing as well. Poor emotional health and well-being as well. Linked with, well, it can cause and be caused by excess weight. So any strategies relating to mental health well-being are very much tied up with being a healthy weight and so on. I'm sure you're very well aware of the building blocks of health, having probably seen this. So the framework is a core part of the health and wellbeing strategy, and there are a number of blocks which sit under that. And we looked at what this might mean from a healthy weight perspective. So all the different building blocks, which you'll probably familiar with from the building blocks framework. So from a surroundings perspective, this would include things like parks, leisure facilities, planning documents, which businesses are given sort of planning go ahead, food advertising, education, knowledge and skills crucial for children and young people themselves and for families, whether they've got cooking skills, culture, family, friends as well. Typically, what might people eat and drink when they're celebrating? One of the things we often get fed back to us is when it's somebody's birthday in school or nursery, cakes and biscuits are often bought in to help celebrate, and sweets for. So there's so many different aspects and of being above a healthy weight. So it's important that everyone recognises that everyone can play a role in seeking to address this. Housing, obviously, space and location. There were many sort of theories around during the pandemic and the increase as well. And some people said the increase in the numbers of those above a healthy weight might have been due to getting outside less, not being able to access green space, and hence the links with inequalities as well. So as you can see, we've sort of looked at the building blocks of health and how they might relate to healthy weight in there. And so we, with partners, have developed a draft strategy. It's currently in draft format. We've put together a vision, which is to enable children and young people to achieve and maintain a healthy weight through a whole systems approach. The evidence tells us that the only way we can make a difference is having a whole systems approach. And emerging evidence all the time from Leeds Beckett University is around the whole systems approach and the steps that can be undertaken. The objectives, obviously listed here, include things like identifying opportunities and gaps, developing and improving pathways where there may be pathways existing already, making sure we build upon those, effective communication, the language that we use, the words, the way in which we speak about healthy weight is really important. And then we've got the strategic approach as well, which the strategy is aligned with the broader frameworks, as I mentioned, the building blocks of health, but also the Every Child a Healthy Weight ambitions. There are 10 ambitions under that, so we've taken those into consideration as well. And it focuses essentially on this approach we've taken, focused on collaboration, systems thinking, community and policy integration, and data-driven decision-making as well. And it does require a long-term commitment as well to have any hope of making a difference. The strategy will adopt a life course perspective. As you can imagine, from sort of day one, pregnancy through to birth and through the nursery years, school years, as children and young people get more independence when they go to secondary and university. It's important that we consider every different step along the way. The action plan priorities, we've sketched out a few actions. We're still sort of working to refine those, and obviously monitoring and evaluation will be key to tracking the progress of our strategy and the work, and identifying opportunities where we could perhaps tweak things or make further changes and so on. And so this is our next steps. This includes a list of our key topics. So there are a number of cross-cutting themes, and actually they are seen also through the Children and Young People boards as well. Probably nothing new there. Co-creation is key, engagement, communication of news and assets, workforce and learning together will be key going forward. We're going to put more emphasis on this. The training, tackling structural inequalities and promoting cultural competency. And the other topics there, and the specific topic areas then include things like actions against physical activity, environment-specific things against nutrition, the multi-component programs and care pathways. We've just highlighted 4 sort of small items of work. So you can imagine this isn't just a thing that will happen overnight. We've been doing work around this. So, for example, the first box there, reducing inequalities and supporting high risk and vulnerable groups. Within that, around child poverty, Healthy Start is a key action for us. We've been doing some work around this now for a couple of years, some project work, trying to train staff and so on. But last year, we did for the very first time a project in which we used the LIFT data as a local authority. We've purchased the LIFT license, and one of the first projects that we've tried actually is a mail out around Healthy Start. We were able to identify households that may be eligible, and we did a sort of comms plan with those families, and it increased our take up by about 6% in that first mail out. So that's a really big jump, and speak to other boroughs, very few people have managed to increase that much in just one sort of key action. So we actually got a mail out that's gone out this week, in fact, for a second time. So we're very interested to see what impact that will also have on the Healthy Start uptake, which is a key thing because it provides both vitamins and it also provides the credit cards that families can use to purchase food, fruits, vegetables, tinned products, lentils, pulses and so on. School streets as well, obviously other colleagues in the council leading on this very successful piece of work as well. They may have previously presented, I'm not sure, at the panel. And then also UNICEF, we've been as a local authority working with a range of colleagues in health and across the children's centres as well to achieve UNICEF baby friendly accreditation, which is a really fantastic piece of work because it gives a very structured, very evidence-based programme in which we're working collectively to ensure staff working with families are trained and able to best support families to deliver sort of infant feeding in the best possible way. And the 4th final box there is funding acquired, and we're currently undergoing a procurement process around young people and an adult service for tier 2 weight management. So that's quite an exciting opportunity for us now. And slides there.
That is wonderful. And before I open up to questions, I just want to say it's so positive to hear about all of the work that the team's doing, quietly kind of beavering with other services. But you can see that you know, from the overarching health and wellbeing strategy, exactly how those building blocks of health interact with the work that we're doing around obesity. So huge thanks to all of the team. I'm going to open it up for questions. Councillor Baines was first, then I'll go to Councillor Conti, and then I'll go to Goulet, and then Councillor Raza, I'm coming your way after that.
Just like to say thank you, officers. It was a pleasure to read the report. So many positives in the report. You've hit upon a few points that I was going to ask anyway, so I won't ask those questions. But how will planning policies such as restrictions on fast food outlets near schools be applied to my ward, Dormers Wells, which is a deprived area and one of the highest in terms of child obesity? And how often will the committee receive updates on progress in high need wards like mine? Thank you.
Anna, I'll come to you.
Thanks, Councillor. Planning policies, I mean, we obviously work really closely with our team, and we did have a lot of feed into the local plan, which kind of sets that wider framework for us. Do you want to come in about fast food restrictions, Louise?
Yeah, sure. So the government are obviously pushing through a range of things at the moment and past few months around fast food and reformulation of products and so on. Locally, we have this as some work that we would like to sort of progress forwards because there's huge potential for us to make sort of further progress on this locally.
Thanks. And just on the other point, Chair, just about the progress, it's that overarching data set. So those indicators around kind of levels of obesity are really long term. There's something we include in a lot of our data websites. So the kind of ealing.data website that has a lot of our needs assessment and things. So it is something we kind of monitor through that. But more specifically, obviously, if the panelists are keen, we can bring back progress on some of the actions if anybody's interested. Thank you.
Is that okay, Councillor Baines? Yep, all good. Councillor Conti.
Thank you. So a couple of questions. One on schools and the role they play. I know, I don't know how long ago, probably 10 or more years ago, there was a whole thing about healthy eating in schools, Jamie Oliver's campaign about the turkey twizzler, etc. What was the follow through with that? So the schools in Ealing, in terms of the food that they serve at lunch, is that to have to meet a certain standard, etc. And then I guess on physical activity, you mentioned over the pandemic, obviously reduction in physical activity. Is there any barometer of a guide of how much physical activity young people do? Because I think there's a perception that probably most of them spend their times on this, talking on social media and Snapchat or whatever when they get home from school, and probably a lot less physical activity. And how do we get people off this or off their PlayStation and actually to do, because, you know, I know access is important, but Eden's got plenty of green space. You know, I think most parts of the borough, most of the 7 towns have parks, etc. So it's probably not necessarily that we don't have enough of that, but how do we encourage young people to get off using technology that is entertainment and actually go back to maybe what people were doing 15, 20 years ago when they weren't at school?
Louise.
Yes. So it's a really good question. And in terms of the green spaces, we're very fortunate in Ealing. We do have green spaces, but it's a range of different things, isn't it? So, for example, this evening now, it's quite dark. You want to have safe spaces for children and young people that they feel comfortable, safe and able to use. Obviously, the weather in the UK is not ideal as well, and having a free space that's safe, for example, in the evenings after school times and so on. There's many different things which can contribute to that. And for many households, they may not be able to afford to pay for club fees to access like a leisure centre or other indoor venues. So there's lots of competing factors. But we obviously, I think clubs are trying to take different approaches, and schools, your specific mention about the school work as well. So some of our colleagues in the school health improvement team are doing lots of work around promoting the levels of physical activity that should be undertaken and promoting opportunities like the Daily Mile we've implemented previously, HIT training as well for schools as well. So there's lots of things happening, but there's certainly a lot more that could also be done as well. But social media is going badly. Oh, schools food as well. Yes, your question about the so the schools which have signed up to the primary caterer in the borough, they do meet the nutritional standards. It was very clear around the nutrient makeup of each of the meals and so on. They do have to abide by meeting certain rules within that. Yeah.
Thanks, Councillor Conti. So Gulo, we'll go to you.
Thank you very much for the presentation. As a carer and a carer of a disabled sibling and having parental responsibilities of looking after children of different ages, I know how hard it is to meet everyone's needs. How does this strategy identify and support people like us, kingship carers and household caring for multiple children who may fall outside the traditional parent models? Thank you.
Thanks, Kule. Louise or Anna? Louise, great.
Thank you for the question. We know that families don't fit a single model, and that a number of households, such as those you mentioned, with carers, kinship carers, and so on, often face additional pressures that are not always reflected in the traditional parent-focused approaches. However, the strategy is based on a whole systems approach, and that includes community engagement, collaboration, and data-driven approaches and more. So we recognise it's a really complex issue, healthy weights, and we will be looking to use a whole systems approach, speaking to households and families to help shape the interventions and seek to address the needs of different families and households across the borough.
Thanks very much, Kule. So I've got Councillor Raza, then I've got Councillor Mataza, and then I'll come to you, Lorraine.
Hi, thank you very much for your presentation, and for the Daily Mile shout out as well, because we're still going strong at Stanhope Primary with our Daily Mile. What I wanted to ask was, how closely are you working together with, I guess, outfits like the Food Bank and Felix and other people who are supplying food to families where they might not necessarily have enough? Because what we have found is there is a definite sort of urge or need by families to actually have fresh fruit, veg, and cook it and prepare it themselves. But quite often it's other things that stops them from doing that. And how can we sort of make that easier? So how, firstly, do you work with them to make sure that that happens? And I did have another one. Yeah, it's more of a point really, because we've opened the hub at Greenford Library, and when we talk to our young people, so teenagers and above, they're all telling us that they want to learn how to cook more better nutritional value food meals for themselves, and that kind of knowledge isn't there already. So is there something in the strategy where we can kind of plug in with that? Thank you.
Anna, I'll come to you.
Yeah, thanks, Councillor. Just to start off and then hand over to Louise for the details. I think one thing that I think is in the slides, we've got a food partnership in Ealing, which has grown over the last few years, which has lots and lots of different organisations and partners represented, which is fab. And the kind of lead role for that we partly fund, because it's such an important part of this. So food's obviously the only one part of it, but I think that link with kind of community groups are out there already doing this, and how do we share opportunities through things like the different websites we've got and things in terms of linking people up, I think is really key. Louise, do you want to add?
Thank you. Yes, the food partnership, food banks represented, and Felix and so on. But there's certainly always more that we can be doing. We've had conversations in the past about trying to influence the food that's offered and so on. But there is obviously more that can be done, and we'd like to build upon that, certainly.
Excellent. I'll come to Councillor Mataza now.
Thank you. Very comprehensive. It's a comment, and then at the end, a small question, is that the journey of obesity starts from very earlier on. Children learn what they live, and the growth and development up until 2 years is basically nutrition dependent. The emphasis should be put on right at the point of weaning, how we start weaning the children, what do we feed them and how much do we feed them, how much we are stretching their stomachs, and basically how much we are developing their habits and comfort eating. At the age of 2 years, growth hormone kicks in, and then but the habits have already developed before that. I think in this strategy, I would like to ask, how much are we putting effort for parental education to specifically on this point? Thank you.
Thanks, Councillor Mataza. Louise, I'll come to you.
Yes, parental education is key, and we are working to sort of upskill our staff as part of the infant feeding UNICEF accreditation programme. So that's a key element. So staff that come into contact with families in the from the health setting, health visitors and so on, but also in the children's centre, because they can help support families then. But it will be a rollout process because we need to ensure that the messaging we get right. I guess it references Councillor Henny's earlier question, really. We need to get the messaging, the wording that we use correct, so we can speak to many different households across the borough around sort of the food and the activity levels as well, and the whole system essentially to support the families.
Thank you very much. So I've got Lorraine and then Councillor Jamu after that. So I'll come to you, Lorraine. Oh, you're micless. No worries.
Thank you for your comprehensive report. You really coined it for me when you said whole system life course approach. It really is the whole encompassing everything. And congratulations on getting 6% more uptake. I think something that's critical here that you've identified is the need for community voluntary sector involvement. And quite a direct question is, what ring-fenced resources are you planning to put in place to support delivery?
Anna?
Yeah, thanks, Lorraine. So in terms of the procurement we've got coming up, so that's very specifically, we've identified a gap over the last few years, which I think a lot of partners know well, in terms of adult weight management services, but also adolescents. So we've got really good resources through our 0 to 19 service for younger children and families. So that will be open procurement, but it's obviously we're really it's based on so much partnership work that's happened over many years. So this isn't just something we're kind of taken off the shelf, and a lot of those partnership groups and feeding in. I think one thing we've talked about for that, plus lots of other things that we're planning at the moment, is how would you have, say, a specialist resource that isn't just over there delivering a service, but actually helps train up, helps provide you know, advice, etc. to others, especially voluntary sector partners. So it's something we're exploring. We haven't finalised at the moment, so we're in that development of the service spec stage at the moment, and then that will go out, but really keen to work with partners to embed that. I don't think, you know, nobody wants to just see a standalone service that doesn't fit in with everything that's already great out there. And there's so many, you know, we've talked about this whole system approach. There's so many community groups out there doing amazing things with families, and from a kind of cultural competence point of view, reducing stigma, access is so key. We're also just as a bit of an aside on that, with the regional park work, we're also we've also set aside some funding for some work and engagement work with communities around the regional park to really ensure that actually it's used by local communities and it's what people need, and they feel it's for them. So really thinking about that wider work there. Thank you.
Thanks very much. So I've got Councillor Jamu next, and then Councillor Steed after that.
Thank you very much. First of all, Chair, I'd like to say thank you for inviting me to this group as well. I will say I went through this report before actually coming to this meeting, and as a school governor of our primary school, this was a complete eye-opener for me. I can tell you that for a fact. And for me, I know schools are aware of nutrition and everything else, but I just wondered if there was like an annual update for heads, teachers, etc., any additional training. And the other thing I'd like to take back is maybe some kind of training for school governors, so that they can make sure that their staff are making sure that they're doing the right thing via health and food. Thank you.
Some really good points there, Councillor Jamu. I'll come to Anna.
Yeah, just to say, Councillor Jamu, I think that's really helpful.
Sorry.
Thank you.
Go on, one more thing, go on.
I do apologise. I'm just thinking about it from another point of view, because my grandson, who is blind and whom I also look after, he's only 14. He has cookery lessons once a week as a high school child. He goes to an outer borough school because there isn't a suitable school for him within the borough. But I just wondered, what is the procedure for Year 9 children in the borough? Is there like cookery lessons? Is there like food nutrition lessons, etc.? Sorry, Chair, I just had to throw that one in. Thank you.
No, PS is always good. So Anna, there might be some questions there that you need to take away from a sort of education perspective, but I'll pass on to you.
Yeah, thanks, Councillor Jammett. I think that's really helpful in terms of thinking about training for governors as well as heads as well. So we do have a lot of our children's team that we work with, and the school healthy improvement team that we fund as well, that does a lot of those relationships, which is great. The idea about kind of annual update and things we can definitely take away and think where that fits in with everything. But I think it's really important. So we put in there about school super zones. We've set aside some funding. It's small and it will be slow, but we had it at Brentside School a couple of years ago, and it really works with lots of the people that work in, go to, live around schools, local businesses, local voluntary sector, and goes, what would make a difference for this school in terms of kind of like a healthy environment. So we did that with some of the London funding, which is great, but we managed to set aside some local funding. So I just think that kind of schools need to own this, and schools need to, there's nothing right in us going out and saying you have to do X, Y, Z. There might be some guidance, but in terms of that, there might be some interventions. I think Brentside was really looking at kind of cooking, healthy food environment, growing, active travel, parking zones, etc. So each area will be different, and I think that'll be really good. Do you want to just pick about cooking lessons, Lou?
Sure. The provision will vary across schools. The new PSHE sort of guidance, which has been updated, the school health improvement team are currently working through updating all of their documentation that they take out to schools, and then the new sort of rules about encouraging things like more useful skills such as cookery skills and so on. They will take that out to the schools, and then it will be up to the schools to sort of run with it a little bit, but they will be promoting it certainly.
Thank you so much. I will say I'm going to be taking a lot of this back to my school and discuss with the teachers there as well. Thank you.
And thanks again, Councillor Jammy, for joining from Children's Scrutiny. Really appreciate that. So I've got Councillor Steve, my Vice Chair, next.
Hi, thanks. Many thanks for the report and the level of detail you go into, and clearly the tentacles cover lots of different areas. But also, of course, it's a 5-year project or plan or whatever. You've mentioned a couple of times, Anna, the word funding. So I just wanted to ask you a little bit about that. Is this all meant to come from your general pot, or only presumably you're seeking some external funding for particular projects and stuff? How's that? I mean, how's that going to work?
That's a great question, Councillor Sue. Thank you. So I think I like the idea of public health tentacles first. So I think in terms of that 5-year plan for public health, that's relatively short. But in terms of election cycles, funding cycles, etc., it's not. We are also building on everything that everybody's done for many, many years. And this isn't just kind of new ideas that have come out and with no plans. So I think in the plans we were saying there's areas that are already there. It's tweaking it, it's improving it, it's learning from it. Areas that we might want to say expand into different geographical areas, different schools, etc., like the school super zone. And some of it's new, and there's a couple of things in there that we're really just starting. So thinking about the food advertising, for an example, is something that we're learning from other areas, and really thinking what we can do to support that here. A lot of the things we've talked about here, especially the kind of healthy weight management services that we've talked about, school super zones, some posts are from public health grant, which is given to the council for public health functions. We've just had that allocated to us now for a 3-year period for the first time in donkey's years, which is good, depending on how you view the numbers, but it's really helpful that we know what's coming in that. We've done an awful lot of work with our borough-based partnership partners and within the council in terms of understanding where that grant is used over the last few years, and really directing it where there's needs. So, for example, the weight management service for adolescents and adults has been a need since I've been here. And school super zones is something we had some pilot money for, but we loved and wanted to carry on doing, and you could really see the benefit. So over the years, we've managed to carve out bits and pieces. I think I talk about funding, and I do this in my team quite a lot. It's just really helpful to be able to move things along, and it's really helpful for us to add into other teams as well. There's so many things in this strategy and the draft action plan that aren't public health, as in it's not from the public health grant, so it might be from NHS partners, it might be voluntary sector time and staff, it might be the parks team, leisure services, etc. So an awful lot of the public health input in there is through our staffing and our strategic work and bringing in the evidence of what works, trying the evaluations, etc. But a lot of this will be from lots and lots of different pots around partners.
I think that's why the tentacle analogy works quite well, actually. So I have to remember that one. Councillor Tighe.
Thank you, Chair, and thank you so much for the presentation. And I was very struck by what you said about the pandemic, and it just reminds us of how hard those days were, and especially I think for children coming out of it. I was thinking about the Let's Go Southall campaign, which is a campaign I love. I think it's just a great idea, contagious motivation. And I wondered, was there any link up specifically with schools, or has that been explored? And it sort of put in mind for me as well Michelle Obama's Let's Move campaign, which I've just had to Google and remind myself of, but I think it's a simple idea that can really motivate people, and we're very lucky locally we have Let's Go Southall. And just a question on, has there been any direct discussions with schools about the impact it could have?
Yeah, thanks, Councillor Tighe. So I actually chair the Let's Go Southall board, so it's definitely my one of my areas that I've spent a lot of time just putting in a funding bid. So we'll see what happens with that. But it's fabulous, and I think you can see so much how that's grown out of communities trying to do something different for their neighbours and for their communities in ways that work for them, at times that work for them. It's great. There's been a lot of work, particularly with schools the last few years, around Let's Ride Southall, which is a kind of free bike scheme. So there's been a lot of work with a number of the primary and secondary schools in that area, and depending on what happens with the plans going forward, that's definitely an area to expand. So that's been one of the really good ways in, I think, in terms of those school relationships, because you come in with a really practical offer and all the wraparound work. And so they've really seen a lot of the kind of like family groups grow. So you get a kid cycling, parent cycling, and actually spending more time together. Do you want to mention just any of the links with Let's Go Southall more generally with this work?
Yeah, obviously they're part of our group and inform the shaping of the strategy to date and so on. And I think it's quite refreshing that it's obviously will help address healthy weights from a very different perspective as well, and from the community and so on. It's quite inspiring, and that I really hope it continues to impact and in the positive way it has done to date.
Councillor Jammy's got a PPS. And this is the final question.
Actually, it's not actually a question as such. It's something I'd like to speak to you outside of this, because in North Greenford, we've earmarked a space for like an after-school club. And if I could get your input on that, that'd be really helpful, please. If we can talk outside the script. Thank you.
Thanks very much. Just wanted to say in conclusion, Anna and Louise, we really value and appreciate the work that you're leading in this space. So thanks so much for presenting this evening. It'd be really good to get an update on how the procurement goes. And then I would hope that the panel in future years, appreciate we've got the elections coming up, but could look at some of the data and start to see the impact of some of the public health interventions that you've talked about. Anna, I'll come to you for a final comment.
Thanks, Councillor Wilson. Just wanted to add, Gule, I know you had a couple of other questions. We've got responses, and we can share those via Anna Marie, and they can be published. So I don't think there's anything in there that we haven't covered in other ways, but I just want to acknowledge that. Thank you.
Thanks very much, Anna and Louise. So we will move forward, colleagues, to item 8 on the agenda, which is the Ealing Community Partners Community Health Services item. Dr. Chris Hilton is Chief Operating Officer at West London NHS. Chris, I wonder if I should come to you and then you could introduce colleagues, and then we'll move into the presentation.
Thank you, Chair. I'm aware that we're pressed for time, so I'm going to suggest that I invite Dr. Neville Cheeseman, who's the Borough Clinical Director for Ealing Community Partners, to coordinate colleagues' input.
Hello, everyone, and thank you for having us here today. As mentioned, I am Neville Cheeseman. I'm the Interim Clinical Director for Ealing Community Partners. Just briefly, just want to tell you what Ealing Community Partners is before we move to the talks. Essentially, it's a lot of the community physical health that sits outside of hospital. It started in 2019 and brought together a lot of those community services under West London NHS Trust, but also in partnership with CNWL as well. And we work with lots of other acute trusts, but also third sector organisations such as Marie Curie, Dementia Concern, and others. We have approximately 45,000 patients at a time under our service and about 900 staff. It covers a wide variety of services, and I won't go through them all, but particularly things like all the children's services in the community, all the physical health services. It's got the learning disability services. We now have older people's mental health services, including our memory services and inpatient units there. Things like district nursing, tissue viability, Clay Ponds Hospital. We do MSK, podiatry, dietetics, and the list kind of goes on. And also more recently, we've taken on the primary care input to care homes services. So we have a wide range of services, which is great because it gives us a real opportunity to look at where we can work together. A lot of our patients are under multiple services. Can we look at how things can work together differently? Prevention. We're doing a lot of work around frailty at the moment to try and improve the outcome of people early on in their frailty sort of journey. So that's a lot of the work we're doing. Today, you've asked for us to come and talk about 3 specific areas. One is our bladder and bowel service. One is core specification work, which is looking generally standardising services across boroughs, and that's some of the work that's going on. And lastly, around the audiology services. So unless anybody has any particular questions around Ealing Community Partners in general, I'll hand over to Susan, who's going to start to talk about the bladder and bowel services.
Thanks, Neville. My name's Susan McCabe. I'm the Associate Director for Ealing Community Partners. And as Neville said, I'm going to just give a brief update on where we are in terms of the service, but also touch on some of the early work that's happening with the core specification work. So I'm not sure how much you know about the service, but it is a specialist assessment service that works with adults and children in the borough to support them to optimise their bowel health. We provide clinics and home visits across the borough. We provide training and education to support the self-management of bowel health. And we also deliver support and advice to colleagues across health and social services, and as well as prescribing products for patients. Current priorities for the service. I think one of the things we've really been focusing on in the last year is looking at the triage and the assessment of the referrals that are coming in and making sure that they're patient-centred and keep the clinical needs of the patient in the centre of it. In order to support that, because we're quite a small team, we've worked on a trusted assessment model with our colleagues in community nursing, and we also have trusted assessors in the care home services, in the care homes across Ealing. And part of what the team does is support those assessors in terms of their formulation when they've done the assessment to make sure that it actually meets the needs of the patient as well as the self-management, because the primary focus is around continence management rather than kind of just thinking about a product at prescribing pads. One of the other priorities we're looking at is aligning with the core specification. As I mentioned, that's on the next slide. We've also undertaken a QI project, and that's to look at the impact that the work we've been doing is having on patient care. And part of that is looking at how we manage our resources, but other areas that we're looking at is developing a booklet that will support patients in managing their own skin integrity, but also recognising signs of infection as well. And
Susan, so sorry to interject. Is there any way that we could just, I don't know who's driving the slides, sorry.
Neville, do you want to get bigger?
Yeah, it would be great if we just put it on slideshow mode. So sorry.
Okay.
Thanks.
And finally, there is a gap in Ealing around the support for people who have indwelling catheters. So part of the work we're looking at is to widen our capacity to offer more clinics to those patients that we have. I put in a bit of information about the containment products that we provide. So we have a contract with Ontex. There's two different types of pads we have. One is for daytime use, which is around 800 mils, and overnight it's about 1200 mils. As adults, we're encouraged to drink 2 litres of fluids a day. Not everybody does that. I think on average we drink between 1 and 2 litres. And when we're assessing a patient, we're looking at what their input is, which gives us an indication of what their output is. So historically, 4 pads have always been prescribed, but we're now moving towards a position where we want to be much more patient focused. So often 3 are seen as sufficient for the patients that we have, which gives about 2,800 mils. We are missing a 0 on there. Just touching on the work of the North West London course specification, Ritika's going to talk about some of the other areas, but just to say this work is just started quite recently over the last few months. Other areas are much further down the line. But some of the highlights we're looking at is inclusion and exclusion criteria. It's similar across North West London. There's a couple of differences in Ealing in that we provide the products for the care home patients, and we also have a children's service as well. It's one other borough that covers both children's and adults, and there's a separate specification being worked up for paediatrics. Referral process that is similar across North West London. One of the changes that will happen is around our KPIs and our response times. So we're moving from what we do currently from 2 weeks for urgent reviews to 4 weeks for routine reviews. The course spec is suggesting that we introduce a much more of a triage focused process, so that we will triage all referrals within 5 working days, do priority referrals within 10 working days, and routine within 28 working days. And the thinking behind that is to make the service a bit more responsive to, for example, patients in end-of-life care. In terms of service provision, there's quite a lot of similarities across North West London. There's the similar trusted assessment model and similar offer for housebound patients. As I said earlier, there is a gap around the catheter support in Ealing. And one of the areas we're looking at is reassessments. We have a very small team of staff. We have 4 clinicians, half a matron and a couple of healthcare assistants, but we have a caseload of just under 4,000 patients. The vast majority of those are for reassessments. The course spec is suggesting that we remove most of the reassessments as the risk is considered low and it doesn't provide clinical benefit to the patient. In care homes, that won't change. We still have annual reassessments for patients, but hopefully by reducing the amount of reassessments, we'll be able to offer further support and more targeted support, as I said, for example, for people with catheters. The next slide gives an indication of where we are as a service. So I think coming out of COVID, the service was in quite a challenging position, and that's because we had to move some of our resource away from that service to focus in community health. So we've been working through our QI and through various changes in our staffing levels to try and address the PTA, our wait list, basically. So if you see from in the first graph, that was from May 2025 when we had 383 18 weeks and below weights, and we've managed to reduce that to 251 in December. We're still not where we want to be, but we're hopeful that we'll continue on this trajectory. And the final slide just talks about the current position. I think since we've come out of COVID, the team has struggled in terms of recruitment. We've had a number of HR issues that we've had to address, but we are now in a position that we are fully established, which is really positive for the team. And we've moved some resource from community nursing into the team to support the work around the wait lists. We are supporting the team in accessing education opportunities at the University of West London, and that will bring us even further in line with course specification, the expectations around staff experience and staff knowledge bases. In terms of the patients on the waiting list, we are working with one of our colleagues who volunteers for the trust and they keep in touch with the people on the waiting list to try and support them and encourage them, but also that helps reduce our DNA, so again helps with our capacity in the service. And as I mentioned earlier, we have a programme around trusted assessors, but we also have a number of champions across our teams and again in care homes. And over the autumn, we developed a forum to kind of bring them together and talk about good practice, to share case studies and to share what works for patients in various settings. And so any questions?
So I think what I'll do at this juncture, if it's okay, because we've got Robert McCulloch-Graham, who is the chair of the Ealing Safeguarding Adults Board, and I know he's been doing some work in this space. So just before we move on to the next presentation, I'll invite Robert. But before I bring Robert in, just to say we'll take questions on all of the presentations at the end. So Robert, did you want to just talk about some of the work that your board's been doing?
Yep. I can do that, and thanks very much for the presentation. It's good to see such good work actually underway. Just as a bit of background, we had a question that came to this scrutiny group here, which kicked off a piece of work that both Kerry, the Director for Adult Social Care in Ealing, and myself undertook on the back of questions that were raised at this group. There's obvious concerns that when we don't get it right around our bladder and bowel services within there, it causes great distress, and particularly for our most vulnerable families and for the carers who are actually looking after people. So there was a great deal of anxiety and a great deal of angst, I think, that was expressed at that time. And so we undertook a task from this group to have a look at what we might do as a partnership, and really looking at the safeguarding issues prevalent within this, but also to look across all of the agencies that are involved. And so you've given a presentation from a health perspective, which is what you were asked to do. But what we've undertaken is trying to realise that the issue around the consequences of not being able to provide the services that's actually desired, it's the responsibility of every service. And so on the back of that, we pulled together a group, and we're now forming a task and finish group, really, and we're involving your services from the Ealing Community Services, also adult community nursing. We've got planned care services, we've got the tissue viability, the bladder bowel services, and clinical services coming in, but we've also got every adult social care service involved across the whole of West London. And so what we want to do with that task and finish group is to look at what input each of those services can actually provide, and a degree of challenge between ourselves. So to both challenge from health and social care, and to see what we can actually do. Beyond this first meeting that we've had, our next meeting is coming up in early March. We want to spread this out to involve our colleagues in Health Watch, our carer communities, and also our service users, to see what we can actually pull together to actually improve the service. And on top of that is actually working with the providers of some of the products that are actually provided as well. So what started as, to be honest, in my head, quite a simple issue, is suddenly broadened out and it's involved a lot of people, but it's also a lot of different areas of work that we could do around improvement. So it's a degree of commissioning services, training individuals, and actually moving some of the practice away from simply providing products, but actually how best to use those products and what other methodologies that we can actually use in there. So it's suddenly become quite a wide piece of work, which is kind of more hopeful because we've got all the right partners around the table now. And I think the importance of the product is really highlighted by the question that was brought to this group. So I think it's a good example of how this group can actually change local policy and probably national policy as well, actually. So I'm quite encouraged by the comments that we had and the input that we had at our first meeting, and really hopeful that we can take this task and finish group forward over the next year and see some significant improvements. Our health colleagues here presented just now have given an indication from their perspective, which is right. But I think that, coupled with the work that we do in care homes, the work that we actually do with domiciliary care, the work that we do with all of our carers that we employ ourselves, but also with the community, and actually engaging with them, I think it's going to get us to a much better place than perhaps that we are currently.
Thank you very much, Robert, and it's really pleasing, as you say, to see that something that started as a kind of challenge from this group has led to some real tangible change with the formation of that task and finish group. So, Neville, I'll pass back to you for the next part of the presentation.
Yes, and I'm going to hand over to Ritika, who's going to talk about course specifications.
Good evening, panel. My name is Ritika Kocher, and I'm the transformation lead within West London NHS Trust for the Borough of Ealing. Apologies, some of these slides are more updated than the ones that you have in your pack. We weren't able to share them before, but we will be showing them after this presentation. So I'm going to be talking to you about the community core offer within North West London and the relationship to Ealing. So just to give you a bit of background, in terms of mental health and community collaboration, we've been working on this within our using our 3 trusts within North West London over the past few years. In the past 2 years, that's been formalised more, where we have identified a need to be able to accelerate a lot of our work. We've had to change some of our structures, and that's led to the identification of 3 priority work streams, chaired by a non-executive director and a chief exec. Known as improvement, place and value and support. And the core offer work that I'm going to be talking about, predominantly the community core offer, fits under the improvement kind of banner. So the community kind of core offer was designed to be able to standardise quality, access and outcomes within North West London to make sure that within our boroughs there wasn't any fragmentation which affected the care that patients were provided. And wherever they went, they could be provided with the same care, whether that was Ealing or Brent or somewhere in inner London. And within that, the programme kind of consists of 4 key components. So we develop core specifications for priority work streams and services. We map the current activity to understand what the gap is and what the variation might be across North West London. And then we identify and implement changes which might be due to additional funding or through productivity improvements within our existing services, followed by an agreement. So we're currently on tranche 1 of this offer, which consists of the specs listed below. The ones highlighted in yellow, tranche 1A, are the most progressed specs, as Susan mentioned when she talked about bladder and bowel, which is a more recent spec. So we'll be giving you information on all of them, but just for note. So in terms of timelines, we're currently, for the more progressed specs, where more specs have been designed, we have mapped variation and we're working towards implementation of those specs. Whereas the other ones, which are more in their infancy, we're still developing those specs, then trying to map what the gap might be, and then how do we develop a common approach going forward. And we're hoping for some of the more progressed specs, which have been going on for some time. Hopefully by the end of this financial year, we'll be able to conclude them to then move on to the backlog of the other services that we need to focus on as well. So from an Ealing perspective, the next couple of slides give you some information on what it looks like within Ealing. So within the 10 specs listed, 50% of the specs, we do meet the core minimum offer, and work is still progressing to make sure that we're optimising how much we're able to offer in a productive manner. We're looking at KPIs, metrics, but in terms of what's in the spec, we do provide that minimum offer. For the specs listed, kind of RAG rated as a yellow, predominantly community nursing, and D2A short-term rehab, we have a spec and we're mapping some of the gaps. For community nursing in particular, which I know is a service which gets flagged a lot from both primary and acute services perspective. The main gaps for Ealing are that we are currently working on a 7-day referral KPI at the moment, and the agreed spec has come to 5 days. However, we don't think that will be a significant challenge because 90% of our referrals are managed within 5 days. So we're making productivity improvements to be able to fill that gap. And then other productivity improvements include making sure that the patients on our caseloads are appropriate for community nursing. So they're housebound and they meet the housebound definition. By housebound, I do mean both permanent and temporarily housebound, where you don't have fixed support to be able to get you to primary care, acute services. So we're working with different individuals in Ealing, including Dr. VJ Taylor, on how do we identify what the principles are to make sure that our capacity is being maximised with the most appropriate patients who are most in need of our services. One thing I did want to mention, which I skipped over, was special schools nursing, which might have come up in other forums. We exceed the core minimum spec far more than any other borough within North West London, which is brilliant for us. But there have been some concerns raised in the past as to whether levelling across means that we need to level down to match all of the other boroughs. And one thing I think we want to reiterate is any formal requests for that, whether that does come through the ICB or through the collaborative, we won't be enacting on any of it without extensive engagement with our health, social care, local authority and school union partners before doing any of that. And then moving on to the ones that are listed in grey, so CYP neurodevelopment, bladder and bowel and TVN, they're listed in grey because right now we're developing specs. We're coming to a conclusion as to what these specs should look like, what should the core minimum offer be. As Susan mentioned for bladder and bowel, the differences include the fact that we and another borough provided children's pathways, others don't. So are we creating 2 different specs managed by 2 different services, or how would that kind of going forward? But we're expected that the spec should be developed by the end of this financial year, but we are in parallel trying to map what the variation might be and come up with plans of what's manageable and what's not. And that in the interest of time, I've given a really quick whistle-stop tour, and we will share these slides around, and I'm happy to answer any questions afterwards as well.
Excellent. So I know the slides have been shared in the pack, so we'll be able to move to questions. Shall we go to the final bit of the presentation?
Yes, thank you. And I'll pass over to Sarah Hume, who can talk about paediatric audiology.
I was just about to ask you if you'd share the slides, but I could see you're about to, which is great. Thank you, Neville. Hi, I'm Sarah. So I have responsibility for most of the children's services that we deliver as part of ECP within Ealing. And I'm going to talk to you a little bit about children's audiology. I know you will have seen the slides, so I'll perhaps try and give you a greater flavour than is in the slides. So children's audiology assessment starts when babies are born in hospital. So all babies receive what effectively is a tier 1 newborn hearing screening, and that screening should pick up the majority of permanent hearing losses. The service that we provide in Ealing is called Tier 2 Children's Audiology. So this is a service that mostly in the preschool years, if parents have concerns about a child's hearing, they would refer the child in, speak to their health visitor or a GP, or refer themselves to come in for a specialist assessment. So what happened last March, we received a visit from an expert advisor from NHS England and colleagues from the ICB to review the service that we were providing. And on the basis of the inspection, we paused the service in order to make a number of improvements. So the key elements of that were identified around some of our governance gaps. So we had some standard operating procedures, or SOPs, that hadn't been reviewed in a timely manner, perhaps hadn't been formally ratified. And that's really important to make sure that everybody's doing the right thing. These children are coming in, there are particular assessments that happen for under 3s and particular assessments that happen for over 3s. And there's a formality about the equipment that's used, how it's calibrated, that needs to be followed. We identified some challenges in the competency of some of the workforce. So perhaps staff training wasn't as up to date as it needed to be, and we recognised that we needed to improve that. And there was some problems with our estate and equipment in terms of calibrating equipment, and some of the rooms were okay for over 3s, not necessarily great for under 3s. So we took a decision to pause the service initially for a couple of weeks, and then having reviewed the information further, we extended the pause for longer in the interest of children and family safety, to make sure that we were going to get this right. I think we want you to know that this is in the context of a national issue that's been raised. You might have seen articles in the Times and various things about the issues nationally. So whilst we're not the only service, we've had the opportunity to learn from other places around the UK and certainly in London. One of the challenges, though, that has presented is in terms of recruitment of audiologists, because everybody's looking for the same qualified staff, and it's quite a restricted group. So in the slides, you'll see that we undertook some short-term actions around the issues that I've talked about around estate and equipment, developing our staff competency and the governance. Staff competency, particularly for assessing children over 3, progressed really quickly. You can imagine it's harder when children are very little, so we're still working on that, but expecting most of our workforce to be ready to undertake those assessments independently towards the end of this month and early in February. We stepped up some clearer governance, so including colleagues like Neville and Chris. So we've had a local operational group involving the staff in the service and the subject matter expert who's been supporting us from NHS England. We've had a steering group to oversee the work, and there's been executive oversight as well, with the chief medical officers and chief nursing officers of both CNWL, West London and the ICB. And then I guess in the current status of the service, like I said, the staff are all competent and now assessing over 3s, and we're expecting that them to be fully independent with under 3s very shortly. We've had some challenges with estate, so we've moved out of Carmelita House quite recently so that can be refurbished. And that's left us with some rooms, as you can see, at Jubilee Gardens and Acton Health Centre. We've needed to do a little bit of work on the room at Jubilee Gardens in order to make it fit for purpose for having 2 testers, which is what you need 2 audiologists, particularly to see the little ones. But where it's left us is we have in order to put all those safety measures in place, we've got a backlog of children, which is now slightly higher than the number you got in your slides. And in order to address that with our current staffing, we know we're going to be able to do that by late summer. But we're looking for some insourcing. So we've identified a company to bring in with some NHS England support in order to help us work through that backlog, to support the children and families to get through them. The other part of the work is a look back over a number of children who've been assessed over recent years, and you'll see that figure of 2,700 children who initially their records and cases need a paper review, and we've got 2 subject matter experts who've now started that. And we expect to need to recall some of those children for another assessment if there are any concerns. And we're expecting to complete that by May at the latest. We've had some really positive news with staffing. So we've got a new lead audiologist, just started with us a couple of weeks ago. The insourcing I've talked about, which improve our capacity. And towards at the end of March, the staff who are currently employed by CNWL, who I work for, will be moving over to West London. And we think that's really important for their retention and their development, because they'll sit with a service that provides both tier 2 and the more specialist tier 3 service. So they'll be able to work right the way across that spectrum. So that's where we are at the moment. Thank you.
Thanks very much. Is that's us covered in terms of presentations? Great. Really rich documents from colleagues, and really appreciate your time. Can I just start on the last presentation and just ask, before I bring Councillor Conti in and others, just in terms of the backlog that you mentioned, if that's growing, do we still have confidence that summer is a realistic timeframe for clearing it? Just wanted to double check that.
Yeah, the trajectory includes a projection of the number of new referrals coming through. Yeah.
That's really helpful to have that assurance. Thanks. Councillor Conti.
Thank you. Thank you for all the presentations. I just had some question about the audiology one. I thought it was quite frankly appalling when I read that this had happened. I guess I had a number of questions, but one is, why did it take sort of someone external for sort of Ealing Community Partners to be aware of what was going on? Because reading the list of failures, weak audit trails, inaccurate KPIs, that's on top of the unsafe equipment, incorrect use of equipment. How come there was no clear oversight that any of this was known, or was it known and was no action taken? I guess that was my first question. The second question is, obviously you're reviewing all those cases. This was identified in 17th of March 2025. Why has it taken almost a year to start looking back over those cases? Because children who potentially have been misdiagnosed with hearing issues, that could be affecting their schooling, their speech development, etc. And sort of potentially another 12-month wait to find out that you need to be retested is obviously a further delay in that. And thirdly, given that this fiasco has happened under Ealing Community Partners, how can we be assured that all the other services that you're offering are being properly audited, properly reviewed to make sure they're safe and up to the standards that patients and residents in the borough expect?
Chris, shall I come to you?
Sure. I'm happy to come back in, given my role as the executive lead in West London for these services. And I agree with you, Councillor Conti. This is a situation that, of course, that we do not seek to justify, and hence the senior oversight that has gone into its recovery. To answer the specific questions that you've raised, I think firstly, the audiology service that we have within Ealing is a particularly unusual service, and actually nationally this audiology challenge has been identified in a number of sites across the country. So it's not unique to Ealing, this problem. There are several sites in in London that have experienced this, and others around the country. In Ealing, we had 2 or 3 elements of complexity. One is it's a tier 2 only service being run within community health services, whereas other more robust audiology services in paediatrics have had both tier 2 and tier 3 elements to them, or have been aligned to acute hospitals with other parts of the audiology pathway. Within that, we ended up having a very small team within a much larger paediatric and children's services department, where the health science expertise that we had inherited when we took over the service was a very small part of the workforce. And health science is a very specific part. This is the only part of Ealing Community Partners that does health science and diagnostics. The rest is about providing intervention and treatment and care. So actually qualified audiologists are these staff within the Ealing Community Partners workforce, and Neville described having around 800 staff. We're talking about single-digit number of individuals with this level of expertise, and of course within that, the others were more experienced about the care that was being provided. That is not to seek that as an excuse, but a part of an explanation. As soon as the challenges were identified, well, you did say, were we aware of some of these issues? Some of them we were aware of. So we had on our risk register for some time concerns about the estates in which audiology was being provided, and the quality of the accommodation at Carmelita House has been on our risk register for some time, with a plan within West London Trust to invest in refurbishment for fit for purpose, obviously needing to be soundproof accommodation. And I'm really pleased to say that through our recent work, we've been able to secure the investment to fully refurbish Carmelita House with a suite of soundproof rooms in order to put audiology in. This threw into focus the assessment of risk, which I think that the Trust had understood to be a risk that could be tolerated and mitigated, but in light of the national concerns that had been identified, the advice from NHS England and the subject matter experts that visited us was that assessment that the risk could be tolerated was needed to be reviewed, and that it would better to pause the service until it could be fully remediated. The stuff that Sarah has described about a decision to bring the service from its isolated position as a small set of health scientists working only in Ealing and only in Tier 2 into West London Trust is possible now because West London became the provider of community health services in Hounslow last year. And within Hounslow, we've got a large Tier 2 and Tier 3 health science workforce delivering the diagnostic interventions, and they including the contract for Tier 3 for Ealing. So by bringing the isolated Tier 2 service into a larger service of health scientists with more senior practitioners, covering both Tier 2 and Tier 3, we can support the development, the governance, and the integration of those services across the two boroughs, whilst still ensuring we're delivering service in Ealing for Ealing residents. And I think we're both confident that that's going to significantly improve the stability of the service. We did declare a serious incident when this was identified to look to see if there were other examples within the Trust of small and vulnerable services. And so Neville and his team have been working through any of the services that may not have come across our radar. As a board in West London, we had seen regular reporting information about the performance of the audiology service, but the key KPI that we look at is a diagnostic response time, which ironically they were reporting good compliance with, but all of this other quality and safety measures was not feeding up in the way that we now expect it to. So the triangulation of that information has now been put into place, especially for small and vulnerable services of this nature.
Thanks very much, Chris. Councillor Conti, any follow-up?
Yeah, I guess on my final point about why it's taken so long to do the reviews of those young people, and then just in terms of the oversight, because obviously you've touched on obviously national issues and sort of estates problems, but in terms of sort of the weak audit trails, the fact the KPIs were incorrect, etc. Where did that responsibility lie, and where is there that accountability? Fair enough at your director level that doesn't come across your desk, but there's layers below that clearly weren't on top. Should they not have been on top of these issues?
Thank you, Councillor Conti. I think that's an entirely legitimate question. I mean, ultimately, the responsibility rests with West London Trust as the lead provider of this contract. But you're right, there is a cascade of individuals throughout the organisation. Some of those individuals are no longer working for the organisation. During the course of the last 12 months, we have worked with members of the team as part of that learning and review process, to understand whether there were competency issues that affected their ability to report upwards the concerns, or whether there were other matters that needed to be addressed. And I can assure you that they have been. To answer your specific question about why it's taken so long, some of those were outside of our control because we were working as part of a national programme which had emerging findings and series of gateways linked with NHS England's requirements around collating the information and the point at which we were asked to do the next steps. Some of it related to local issues in relation to understanding the data and understanding how we would then respond to it. And some of it related to our ability to secure subject matter experts who had access and the right governance to look through all of our records and to be able to then commence that look back and where necessary recall process. I think if for full candour for the committee, we're slightly behind where we would like to be, but we're not a lot further behind than a number of other services across the country because of the challenges finding qualified subject matter experts and appropriate sites in which recall can happen. And I think finally to say this is not now only being monitored within the trust and within our services as providers, but we're working closely with the regional health science team to make sure this is monitored and reported regularly, and they are holding us firmly to account right the way up through NHS England into the Department of Health to ensure that we meet the recovery, look back and recall trajectory.
Thanks very much, Chris. I'm going to move us on to Gule.
Thank you very much. My question is related to the bladder and bowel service. Thank you, Robert, if you're still online, for providing the update. And it was triggered by the work that Robert's team is doing, was triggered by my lived-in experience as a carer. I was at one point a carer of 3 people using incontinence pads in the community. One of them waited 8 months and died not having had his ultrasound done because he was issued the wrong pads. And when the carers were closing the pads, they were ripping, and we had to wait. And we were told that he needs an abdominal ultrasound to justify the change of pads. Unfortunately, that didn't happen. My next question, what's hit a raw nerve here, is how was the decision to reduce daytime continence pad provision from 4 pads to 3 was made, and what evidence underpinned this change? Was any quality or clinical impact assessment carried out before implementation? Were carer surveys done? Were patient surveys done? And recently, the product have been upgraded. Their design has been changed. I've called and logged in 2 complaints, and I've been told that that product cannot be changed and cannot be switched, because that's what that person has been issued with. Now, what can be done? What work can you do to see that this does not happen again? And this has been happening since 2018 when I became the carer of the first person. Thank you.
Thanks, Gule. I'm going to put those questions to Susan.
Thank you. In terms of your question around the change in the number of pads, so I think it goes back to what I said, that we've over the last year moved to a real focus to look at individual patient care. And I think traditionally we always give out 4 pads, and that was always to support sometimes carers coming in 4 times a day. But we've, as I said, moved to that much more focus on what patients actually need. There is no clinical indication that people should need 4 pads, or generally people should need 4 pads. Of course, there's exceptions. So we're working to make sure that the assessments reflect the patient need and that the pads that they get reflect what their output will be. There has been changes in the pads. I think there's been an attempt to improve them. So I understand now that there's an indicator on the pad which kind of shows how much of it has been used and kind of how much life is left in it. So there has been changes around that. I'm sorry about your experience and that you put in 2 complaints. I'm happy to have a look at them for you. Were they recent? Were they over the...
I think
Okay.
rather than getting into the specifics, if you wouldn't mind, we'll pick that specific example up offline. I can see, Chris, you wanted to come in.
Thanks. I don't want. I'm not going to repeat what Susan has said, but I also I'm sorry that Robert isn't on the call, but I really wanted to welcome the work that Robert described, and the opportunity that will bring to allow us to work with carers, to work with local residents, and the different parts of the system. I know our team is involved, but also lots of our other teams, the nursing home team and the district nursing team, etc. And it does segue nicely into the core offer work that's being developed. So I'm hoping that through the work that Kerry and Robert have described, with input from yourself and others who've used the services, we can make sure that core offer both has a clinical basis, as Susan has described, being patient-centered, but also we can learn from your experiences of the real life impact of using the service and the products when we're not there.
Susan, did you want You look like you were mid-flow, so I'll just come back to you for
Yeah,
any final
I
words.
just wanted to add that I think one of the emphasis we've tried to put on the service is that we're there to promote continence. Because I'll give an example of some of the work that we've been doing in care homes recently. We had a case that our matron's been supporting of a care home resident who had mobility issues, didn't have continence issues, but had mobility issues. And overnight, the care home were putting the patient in pads rather than using equipment or supporting the patient to actually go to the toilet. So that's the kind of work we're trying to do for patients who maybe their primary problem is not continence. And I think in the past, it's always been the solution is to give the patient pads, whereas we're going to patient, if we think about patient dignity and their health in terms of skin integrity, I think it's better if a patient isn't put in pads that doesn't require it. So that's some of the kind of focus we're trying to look at and move away from just thinking it is just about giving products.
Thank you very much. Now, I know, Gule, you feel very strongly about this issue, so I think that...
Just wanted to add, the indicator that you mentioned on the pads in the new design has always been there. It's not something that's been added now. So just to let you know that you're aware that that's not the design change that's happened.
And I think definitely the passion for this topic comes through. So let's make sure that we foster that conversation, so that you can share more of that lived experience, because that's why we have co-op team members on the panel. So thank you. Councillor Baines, you are next.
Thank you. I, as a parent, just want to ask a question a little bit about the backlog for initial assessment, and where you said there could be a reassessment for some children. So just as a parent, I mean, you know, a child going for audiology assessment in itself is such a worry. Will you be contacting, if the child has been given a plan, which is a wrong plan, and those parents are on that plan now, hopefully they'll be contacted and told that, listen, this was a wrong plan. And if the schools are in touch with those parents, will the schools be contacted, GPs, to say, look, stop that plan. Actually, that was the wrong assessment, because, sorry, that's all I want to ask. Thank you.
Yeah,
Thanks,
no, it's a really good point. Thank you.
Just also, because we have a lot of residents that can't speak English as a first language, to also, how will you relay that information? Sorry to
Yeah, thank you. So in terms of communication, there is regular communication out to children, well, to families of children waiting for initial or review assessments, so that we've told them the service has been paused while they're waiting. And I think about 3/4 of those waiting are waiting for review. So they've already been in and they're waiting to come back. That information is on the website, it's going out through letters, and we use the relevant interpreting services and things. I guess that, coming back to your point, perhaps the more worrying thing as a parent might be if you've received one type of assessment and then you're then being called back in, and we recognise that's really worrying. So we've worked closely with the National Deaf Children's Society, who've done lots of co-production with groups of parents to frame our communication and letter in the right way based on the experiences of families. So once we, as I said, we've just started, our experts have started to work through that rather high number of children who we just want to check that the assessment was conducted appropriately, and any communication going out to any families where we would like to bring the child back in for a further assessment has been very carefully crafted in line with the National Deaf Children's Society advice. Is that helpful? Yeah.
Thanks very much. Any further indications from colleagues? Ratika, you thought you got off lightly. I am going to come back to this point about special school nursing, because I don't think it should be about a race to the bottom. I think it's really important. We've got something to demonstrate in Ealing, which is particularly special, and so I'll certainly be making those representations at a North West London JOSC level, but I think it was an important point that you raised, and I can see that Nehal wants to come in on that.
Thank you. And my colleagues are really aware that ever since I heard about this, I have been making a lot of noise to make sure that that doesn't happen without a proper consideration about the implications and having proper mitigations in place at all. So that is why I think it's been a recommendation that if any changes were to occur, it would be done working with all of the partners and not as in the timeline that was originally planned.
That's really helpful. Thanks, Nehal. And I think we would expect as a committee to be engaged on that issue. Chris.
I won't delve further specifically into the line of special school nursing, but the general principle that I think Ritika made, I think is a really important one. And I have been advocating on behalf of West London Trust in all of the work that we're doing with our collaborative partners and with the ICB, that the intention of this work was to establish the core upon which local places may wish to build upon, and to make sure that everyone had a core that was consistent. And certainly I am using this and articulating with my teams that we should be levelling up our services to meet that core. Where we already exceed it, it is certainly not our intention to have a race to the bottom, and certainly not without any appropriate communication and consultation. I'm happy to make that undertaking on behalf of the trust.
Music to my ears. Thank you very much, Chris. So I think thank you, colleagues. Appreciate robust discussion, but we appreciate your responses. We'll move forward. So the next item on the agenda this evening is in relation to primary care access. So I'm handing over to Neha or directly to Vijay. Vijay. I should just say, colleagues, appreciate that some of you may have other places to be, and that's entirely fine if you did want to exit the meeting. But Vijay, over to you.
Yeah, just introduce myself. First of all, I'm Vijay Taylor, I'm a GP. I'm also the Borough Medical Director and the North West London lead on access. I am conscious of the time, and I'm mindful that colleagues do have questions. So I'm not going to go through the slides line by line, but I'm just going to really just highlight some important aspects of the access programme that we've undertaken in Ealing and in North West London. So in April 2025, North West London launched an access specification as part of the single offer in relation to general practice and PCNs. There were three main areas that we wanted to address. One was on accessibility, the other around continuity of care, and the third one about patient engagement. And what was important in terms of how we looked at these three areas, that we needed to ensure that there was health equity as part of what we're trying to achieve. Ultimately, our ongoing objectives in relation to access into general practice and in PCNs is to ensure that we deliver high quality patient care at local general practice. We enable practices to manage demand, but also to make sure that continuity isn't sacrificed. And also in terms of the system, it's to support the system in relation to pressures in the urgent and A&E space. In relation to what we have achieved in North West London and in Ealing, one needs to remember that in October 2025, as part of the GMS national contract, all practices in England have to offer online consultation submission throughout core hours. And this was quite a significant change for some practices in Ealing to deliver that. And so practices had to work through their organisational structure, how they managed triage and navigation to ensure that they're able to fulfil the contractual requirements of providing online consultation access throughout core hours. I think it's important to note that in North West London, we have delivered 11% more appointments than any other area in London. And by the end of this financial year, we will be on track to deliver over 17 million appointments. But we continue to try and improve and strive to ensure that we are meeting the needs of the population, and that's ever so important. There are variations in relation to access when you look at the slide deck between practices, between PCNs and between boroughs as well. And what we're trying to achieve is it's important to recognise that there will always be levels of variation. However, what we're trying to do is to try and reduce the unwarranted variation in relation to access, because we do know that there are individual practice characteristics, there are workforce profile differences, there are demographic differences, and there are also disease burden differences across North West London, which one needs to acknowledge and recognise. What's also important to remember that it's not just about general practice providing access. We have the wider primary care delivery of access, particularly in relation to community pharmacy, who deliver minor ailment schemes, as well as the Pharmacy First. The Pharmacy First particularly has been an enabler in terms of delivering access. The 7 conditions as part of Pharmacy First are conditions which are present routinely in general practice. Just to name a couple, urinary tract infections in adults, throat infections, earache. These are common presentations which now Pharmacy First are helping and support general practice to deliver. We also have our dentistry colleagues. In North West London, we commissioned our urgent dental care pathway. Recently, we are started a pilot looking at case finding of dental caries in children, and also in Hillingdon as part of our dentistry inclusion work, trying to support dental screening in our vulnerable asylum seekers as well. So in terms of what we are doing going forward, the access specification will continue to for 26-27. We strive to ensure that accessibility is very, very important, particularly in relation to the responsiveness of our telephony systems within our general practice, our ability to turn around the online consultation submissions into general practice, but also to ensure that we continue to provide continuity of care, having systems and flags in the GP system to recognise our highest risk patients for continuity, but also in terms of how we deliver continuity, having teams within general practice to manage and preserve that continuity of care, because we do know that in terms of patient outcomes, continuity of care demonstrates much better outcomes than the episodic reactive care that unfortunately we have had for a number of years, particularly in relation to how the COVID pandemic has been quite a negative experience in relation to that. I'm going to pause now to allow some questions.
Thanks, Vijay. I was starting to think we might need sleeping bags, but Alan, and then I've got Councillor Mataza and Goulet.
Thank you. What interested me was when I was looking at one of the graphs was Ealing online consultations. 4 of the primary care networks actually have 2 to 3 times more usage of the system. So what are you actually going to do to improve the other 4 primary care trusts, and how does that as a whole, Ealing as a whole, compare to other primary care trusts across other sectors of the North West London area?
Oh, could you use your mic? Sorry.
Absolutely right. There is variation across Ealing in terms of online consultation submissions, particularly as you noticed, North Southall, NGP, Greenwell, PCNs, in terms of the level of submission into those practices compared to others, there's a significant difference. Some of this is related to the demographics of the population that those practices serve, their inability or their lack of skill to be able to complete an online consultation, their preference to use telephony to access those practices. So I guess what would be more important to compare the online consultation submission versus the telephony access, and by comparing it like for like, you will have a much greater picture in relation to how individuals are actually accessing care into GP surgeries. So one can't draw conclusions as to whether it's actually a positive thing or a negative thing in terms of the variation. One needs to just recognise that there are many modalities of access into general practice, not just online consultations, and we will always have that variation.
Alan, did you want to come back on anything?
It was just the other part was, how do we compare to other areas? Particularly if we're thinking about people using computers, language, etc. You can compare, say, Ealing with Brent.
So when we look at the variation across boroughs, there are some boroughs where there are exceptionally high users of online consultations, particularly Harrow and particularly Hillingdon. That may reflect the digital expertise and the knowledge of the general population in those areas. Areas like Brent are very similar to Ealing in relation to online consultation submissions, and again it reflects the population demographics, their confidence and experience in terms of developing and submitting online consultations. We do know that in some practices who have a total triage approach, when patients do come into the practice, the reception staff actually complete the online consultation submission for the patient to try and support their access into the practice as well.
Thank you very much. Councillor Mataza.
Thank you, Chair. First of all, I would like to appreciate the great work which my colleagues have been doing in Ealing. I have the privilege to serve the Ealing community for just over 2 decades, and the service change, especially in accessibility in the GP land, which has changed in the last 1 year. We have never witnessed it before. The different aspect of access, online, e-consult, video consultations, telephone calls, and pharmacy first, they might have some weaknesses in the processes, but overall it has improved quite a lot of services in terms of access. Especially the out of hour and the hubs at the PCN levels have increased the smear tests uptake, childhood immunization, especially for those people who were not able to come during core hours. So contributing to your questions and answer, there are some areas in the borough which have a very limited access to computers and the skills to utilize this service. We are one of those practices where we are facing this. We have requested Royal College of General Practitioners. They are doing a pilot project where they are coming and training staff how to cope with this lack of skills of their population to use this e-consult and online services. And there has been some propositions and suggestions to change the structure of the staff, which will improve in coming areas. Now, my question is that we have changed, one of the changes which we have made is the cloud-based telephony. And the morning 8 o'clock rush is, I mean, no matter how many lines you open, no matter how many people you put to answer the calls, and I have myself witnessed in the morning that after certain number of calls, the calls dropped in themselves. It's nobody's fault. Is there any way we could improve on this particular point, that even the cloud-based telephony is not being able to cope with the morning rush of the telephone calls?
BJ.
Yeah, just a couple of points around that. I think historically, when we had the analog system, we had no transparency, no data about the level of call volume coming into general practice, and we had no idea of the success rate of being able to get through to the phone, and also the number of calls that had been dropped. Now that we have cloud-based telephony, we're able to see that data. We're able to see the number of calls that are coming into individual practice. We now have functionality to allow patients to be call handled within the system, and so that patients, rather than waiting on the phone, can ask for a callback, an automated callback, so that when they're at number 1 or number 2 in the list, the system will call them back so that they can continue their day, continue what they're doing, without having to hold on to the phone for a certain length of time. In the access specification, one of the key performance indicators, and which we ask PCNs and practices to deliver, is that 90% of all your incoming calls need to be answered within 10 minutes. And initially, this was a very difficult task for practices to undertake, but practices had to put in systems and process in place to enable them to do that. And when I look at the data now, I see a vast improvement at an individual practice level, where practices were initially at 30 or 40% answered called in 10 minutes. They're now reaching 70 to 80%. So that is an improvement. And I think we will continue to improve on how we manage that. The cloud-based telephony also helps practices to do some demand management in terms of the number of reception staff that you require first thing in the morning, because as Councillor Mataza says, we have the 8 a.m. rush when we have an influx of calls. Your cloud-based telephony you can look at the data, you can see that, yes, in the morning we need an extra 2 receptionists to handle calls. In the afternoon, we only need an extra 1. But because we got cloud-based telephony, you can actually look at that. There are other technologies coming upstream to support call handling into general practice. There are AI products now being developed that will allow, when patients do call up the practice, there's a level of using artificial intelligence screening to capture the issue, the concern that the patient has in a transcript that then gets processed by the practice, so that the practice can then screen what urgent needs need to be addressed here and now, and what can wait later in the day, or what can wait the next day. So I think there'll be much more revolutionary changes in relation to how we deliver general practice. And then finally, as you know, as part of the 10-year plan, the NHS app, everyone talks about the NHS app and what the next generation of that NHS app will be able to deliver in relation to access into general practice.
That's great. Thank you very much. Goulet, I know you always have lots of questions. I'm just going to take one if that's okay.
Thank you. I'd like to congratulate you on the introduction and the improvements that have been made on eConsult. As a carer, eConsult has made my life so much easier and so much better, and I have more time to myself now. My question is about the NHS 111 redirection. Only 40% of GP slots allocated to NHS 111 were used in 2025. How is your team reviewing mechanisms to improve utilization, and what are the barriers to achieve at least 50% target? When I dialed 111, I always have to wait 2 to 3 hours before a GP calls me back. So I don't know how you've come up with the 40% slots that have been allocated to NHS that have been used. Thank you.
PJ, short reply, please.
I'll try and keep it short. So just first of all, just a little bit of context. Across London, all of the ICBs in terms of utilisation are between 30 and 40% across London. Northwest London has been the highest utilisation of 111 slots. One needs to remember that as part of the contract, each practice provides one slot for 111 per 3,000 patients. So if you have a 6,000 list size, you would provide 2 slots per day. You would put 1 slot in the morning and 1 slot in the afternoon. These slots are time dependent. So if you put a slot, practice puts a slot at 10 o'clock in the morning, a patient of yours rings 111 at 11 o'clock, that slot is gone. So hence you will never get 100% utilisation. What we've been doing in Northwest London is that we've been working with practices to look at a work list approach in terms of how they are providing slots, particularly for the larger practices who have to provide 6 to 10 slots per day, in relation to how you evenly spread those slots out throughout the core hours rather than bunching them up all in the morning or all in the afternoon, so that making sure that we get as much utilisation as possible.
Excellent. I've got 2 more indications, and then I've got a question from Ealing Save Our NHS. So I'm going to limit it to that if that's okay. So Councillor Baines, then Councillor Conti after that.
Thank you. So my question was just about residents. Many residents in Southall prefer in-care face-to-face appointments in practices due to their language or cultural complex issues that they may have. So how would practices deal with that high demand and obviously meeting targets of the digital app?
BJ.
So in terms of face-to-face appointments across Northwest London, GP practices are providing approximately 70% of all appointments are face-to-face. Clearly, when we had the COVID pandemic, that really went down to about 30% for lots of reasons, and we know what those reasons are. When we came out of the COVID pandemic, the practices had to, in effect, change some of their behaviours to get back to the levels of face-to-face appointments that we had pre-COVID pandemic, and we are getting there. However, some of our patients do prefer telephone appointments rather than coming into the practice face-to-face, and there are certain situations, conditions, and needs that can be quite adequately managed by a telephone appointment or a video appointment. However, there are individual demographic circumstances one needs to consider, and I know that practices continually review their face-to-face access into the practice to ensure that they get that right balance between face-to-face and telephone, as well as the online consultation. And it is a constant moving feet for practices to ensure that happens.
Thank you very much. Councillor Conti.
Just a very short question, a follow-up from what Goulet asked about those 111 slots. Is there any way of looking, because obviously I was surprised, but just a 10% increase would be 18,000 extra appointments, which if it's 100% utilisation, I can't do the maths now, but that'd be tens and tens of thousands more. for example, A&Es to book into those slots, or to utilise them in another way? Has any work been done? And obviously, that I know there's like systems that would need to be set up, but has any work been done on that front?
Yeah, so at the moment, the automated seamless connection is between 111 and the GP practice. We have started to look at how we can utilize those slots with our urgent care colleagues, and so in our new revision of the specification for 26-27, we are trying to work through how the urgent treatment centres and A&E can also use those slots. However, we haven't got the integration yet, and so it has to be a more or less a clunky manual process at this point in time to book those patients in. But we are mindful that we want to try and maximise the utilisation of those 111 slots, because they are a valuable resource that supports the whole system.
Thanks very much. So Sarah Boston from Ealing Save Our NHS has posed a question, so I'm just going to read it out. At the last Scrutiny Committee meeting on the 27th of November, we were told, to quote the minutes, that the Jubilee Gardens Health Centre in Southall had been selected as one of the first public-private partnerships to become a neighbourhood health hub. What is the status of the proposed Southall hub? Ealing is not listed as one of the government's chosen 43 sites across the country for a new neighbourhood health plan. Hillingdon is. Their hub is to be based at the Pembroke Centre in Ruislip Manor. Local hubs, GP-led, supported by many other health professionals under one roof, could be of benefit to patient care, but given the history of PFI, public finance initiatives, the benefit has shown to be primarily for the investors at great cost to the taxpayer. What guarantee can you give the people of Southall and taxpayers that the deal done on the proposed public-private finance health hub will be run for patients and not for profit?
Thank you. I'll answer this one. So this was announced just before the last budget. It is part of the NHS Neighbourhood Rebuild Programme, which is due to be ready for 2030. It's already a fantastic asset, a health centre which has a library within it, within our North Southall neighbourhood area, and the work has already started in working with all of the people using the building to make sure it is reconfigured by 2030 with that additional funding to make it fit for purpose as a neighbourhood hub.
Excellent, thanks very much. So we now move to item 10. I did say it was going to be a marathon of a meeting. Neha and Vijay we'll keep the update short and sweet, but this is the NHS North Central London and North West London ICB Place and Neighbourhoods item. Over to you.
Thank you. So I have previously been to this committee and I have shared the changes that are being planned. I'm not going to go through all of the slides. I'm just going to pull out a few key points and then happy to open to questions. So as a reminder, all ICBs up and down the country are required to make a 50% reduction in running costs on top of all of the costs that have been saved. In order to do that, the ICB is being asked to turn into more of a strategic commissioner than doing all of the work it does now and providing some of the direct support to residents. And as you can imagine, there is a lot of work associated with trying to think through the implications of that and how we work with all of the partners to think about how everybody takes different parts of the responsibility. A consultation for all of our staff was launched in December. It closed on Sunday, just gone, and the executive team is now considering all of the feedback to respond to with final structures in that last proposal, there is just not enough funding to create place-based teams, as have historically been here, which myself and Dr. Taylor are a part of. Anybody choosing to take voluntary redundancy will exit by the end of March. But anybody not choosing to take that route and trying to secure a role, the limited number of roles left in the Integrated Care Board, will carry on to a selection process, and in the early part of 26-27 possibly be made compulsorily redundant. They have to make this saving to achieve the £19 per head. That this doesn't affect the commissioning budget, just it's really, really important to say that, not to concern anybody about level of care delivery. And it's fair to say that the work is still continuing with local partners to ensure the borough-based partnership, which you've heard a lot of talk about today, continues in Ealing. West London NHS Trust has been nominated as our host integrator organisation for Ealing, and we're working closely with West London to understand what that means and trying to get some clarity on that. The new ICB will cover North Central London and North West London, 13 boroughs with a 4.5 million population. You may not have got the notification, but today an interim chief executive was announced, Katie Fisher, as Francis O'Callaghan leaves at the end of this month. The structures will have to change to deliver all of the functions it's required to do statutorily, and the ICB is absolutely committed to undertake those statutory functions going forward as well. And that is why some of those staff and the budgets have to go towards focusing on those statutory functions. The slides give some of the thinking about how the ICB will work and the role they envisage local providers or the integrator to step into. There is a lot of work to do over the next 8 weeks, I would say. So I'll stop there.
Thanks very much, Neha. And we did see the news actually about the new chief exec, which we circulated to the panel earlier today. So thank you for that update. Can I open it up to questions from colleagues? I've got Goulet. So again,
it's short and quick.
Thank you.
Thank you. Something just came to my attention yesterday, and it was to do with the community dietitian team, and their team has been cut by 60% or more, and they cannot do home visits anymore, and it's because of the uncertainty, and they haven't been reassured that what's going to happen with them. So how will workforce transition, voluntary and compulsory redundancies be managed to retain expertise and ensure neighborhood level care delivery is not compromised? And this needs to be addressed now before the 2026 merger. And ICB Direct, the HRA, organizational planning and capacity management, needs to be decided between the ICB and the partnerships that work together.
So Goulet, slightly outside the scope of this item, but Chris is here fortuitously, and I know he'll respond.
Goulet, I guess speaking in the general terms with regard to the item that we're talking about, the running costs of the ICB that are being cut are not related to the direct service provision for individual patients and their families. Through Ealing Community Partners and Neville Services, are responsible for running the nutrition and dietetic service for the London Borough of Ealing. There have been no changes to the workforce in the nutrition and dietetic service. If you have been reported otherwise, I'm really keen to hear why you've heard that, because there is no change to the headcount or their ability to do home visits, and we'd like to investigate further. Thank you.
So Goulet, I might suggest you have a conversation offline in relation to that. That'd be great. Any other questions from colleagues? I know that Roy, you have some questions. I spotted you in Cafe Nero earlier. I hope you had enough caffeine to fuel you through the meeting, because you have had to wait very patiently for quite some time. Did you want to just cover the 3 questions in one, and then we can get responses for you? That'd be great.
Yeah, thank you, Chair. Yeah, I find it very difficult to frame a question around this report because as it has been said, there's a lot of management speak and there's a lot of things that are still being worked on. And I understand that, but the only way I could do it really was to ask some very clear, straightforward questions and just see what happens. I realize this report is going to be followed up by other reports which will define the whole situation. But anyway, the first question is the commitment to reduce running costs of the newly merged ICB by 50% seems very dramatic. Is this a realistic aspiration objective? Is it how will it be done, and what's the timescale that has been allowed for that? The second question is the new ICB will be a very large commissioning organisation, as we've already heard, covering 13 boroughs and nearly 50 neighbourhoods. I'm not absolutely clear what a neighbourhood is. I know I live in a neighbourhood and I expect some local facilities to be in that area, but how does a neighbourhood, how big should it be in this definition? And how does it differ perhaps from a hub? But anyway, and the second part of that question is how will they safeguard and stabilize how will this new merged ICB safeguard and stabilize health and social care providers in what is already a fairly chaotic market with some providers on the edge of financial collapse? And third question is, will the new ICB be able to secure the future of Ealing Health Watch as part of local accountability, which is one of the headings in the report, local accountability, and it would seem to me that Ealing Health Watch is a very important part of that. But my organisation, SGAG, is concerned about the Health Watch report on the transition of Ealing Careline to Harrow Careline. That's not yet appeared on the work programme for the Scrutiny panel or for the Health and Wellbeing Board. So,
thank you. Thank you very much, Roy. Before I just invite Neha to respond, I'll just pick up the point around the Health Watch report. So that was published on the 9th of January. It will be circulated. It's on the Health Watch website. Sadie's nodding there, which is, yeah, no, it very much is. And we'll make sure that that is circulated to members of the panel for information. Neha, should I bring you in?
Thank you. In terms of the first question about the 50% reduction in running costs, it is a really, really difficult ask. We've all been struggling with how to do the work that we're going to have to do within the £19 per head as an integrated care board, which is why the integrated care board has to change how it works, and that's why it's now being asked to focus on being a strategic commissioner and work with provider partners to transition some of those parts of the responsibilities that the ICB used to do, which are direct patient care, to some of our providers in the future. So hopefully that will mitigate some of the risk, but it is a really difficult ask, but it is a national ask that has been made across the whole country. The second question around neighbourhoods and how the ICB will undertake such a huge commissioning function. Part of the thinking behind the organisation of the teams within the new integrated care board, there is something called a strategic commissioning oversight unit, which is basically going to look after all of the contracting and commissioning, will have expertise and skills to work with all of the providers it is commissioning and to work effectively with them. There are lots of contracts that the ICB still has to manage, but the systematic way of working through them is by creating and focusing all of that within one team. We'll see how that team develops as a result of the feedback from the consultation as well. And then the other part of that question around what are neighbourhoods. So I've presented in the past about our neighbourhoods, but neighbourhoods, just think of it more about how we organise our teams to serve populations of around 50 to 100,000, so we can provide more coordinated care across a number of agencies for that local population, rather than trying to do and spread teams thinly, trying to provide more localized care. So we've talked about Southall, for example, might be very different to the needs of Central Ealing. So that was that one. And the final question around Health Watch. I'll be honest with you, I don't think we've had that conversation around securing Health Watch in Ealing in particular. I know that there will be lots of conversations going on about how to ensure that we're doing the right engagement and working with our local authority in this space as well.
Thank you very much, Nehar, and thanks again, Roy, for the questions there. Nehar, I think you said the situation's particularly going to be fast moving over the next 8 weeks. So we'll make sure that we factor in a further update at the next panel meeting. And thank you, as always, for your candour in responses to the questions that have been posed. Item 11 is just to confirm that the date of the next meeting is the 17th of March. Can I thank all of our presenters this evening for joining us, and to my panel colleagues, can I say thank you ever so much for your questions. I think it's really important when we come here, we offer that constructive challenge, and I think it's been great to see everybody participating in the meeting tonight. Have a good evening and see you very soon.